Hello, everybody. Welcome back to our weekly webinar. My name is Sam Alamayo. I'm a 2004 Ron Brown Scholar and a Board of Trustee. I'm here with my partner and fellow Board of Trustee, Meredith Eggers. Meredith.
Hi, everybody. Thanks for coming. I'll say what I say at the beginning of most of these, which is just remember that this is a place for conversation. There's no question that isn't acceptable or that you should feel uncomfortable asking. There are times when the conversation may get a bit uncomfortable for someone, and that's what we're here for. We're here to confront the difficult topics of our time and hope that but make sure that we come out on the other side with actionable items and we move beyond this. So thanks for coming.
Awesome. I'm going to start with a quick introduction of the Ron Brown Scholar and introduction of our fantastic panelists today, where we're going to focus on COVID and COVID's impact in our community. The Ron Brown Scholar Program is dedicated to nurturing the next generation of African-American leaders. The scholarship honors the legacy of the late Secretary Ronald H. Brown through a selective scholarship program that advances higher education for community-minded and intellectually gifted African-Americans. The program supports students before entering college through the Guided Pathway Support Program, or GPS, during the college years through the scholarship and mentoring, and after graduation through mentoring and networking programs. Each week, members of our awesome RBS community will share the panel to discuss relevant topics. Today, we are addressing COVID, and we have two doctors in the room. And the first one is Dr. Travis Gales. Travis is a 1997 Ron Brown Scholar, and he's the health officer and chief of public health services in Montgomery County, Maryland. And he's very important to me because that's my own personal county. And a lot of school parents' rage is directed at him. And we have Dr. Antonia Henry. She is a Ron Brown Scholar, class of 1998. She's an Associate Chief Clinical Officer at Metro Health in the University of Michigan. She's just transitioned into civilian life from the Navy after spending over 7 years, right, in the Navy, and most recently on the USS Theodore Roosevelt. I'm going to start with you, Antonia. You know, we started this program, kind of the weekly webinar, because of what COVID has done to all of us, locking us up in our room, and the sense of community has never been more important. And the questions that we all have that is related to the disease, as well as the impact in social injustice, has been quite acute. Can you tell us a little bit of kind of your experience of going through COVID and transitioning into civilian life right now, and the impact COVID has in really restarting and resetting everything that we know, and most importantly, the way you see it kind of impacting health relations and the health disparity that it had exposed within our African-American community. So I just threw a bunch of questions your way, but I just wanted to get you started.
Talk about everything. So thank you for inviting me. I'm so honored to be a part of the webinar this week, and I look forward to engaging in this conversation. Most of my experience with COVID pre-civilian life has been in the military, and at Naval Medical Center San Diego. And I remember back in March when people were in and out being sick with the flu, there's all this uncertainty. I think it really laid bare our inadequate preparation for emergencies. In the military, there's a lot of preparation for terrorism or for acts of war, but for something like this, which is probably much, as we now know, much more likely to happen again in the future, we were very, very, very inadequately prepared from our logistics in terms of getting the necessary equipment, the way that we train and prepare our first responders, and the way that we educated our patients. And so I hope that we take this as a learning opportunity, and I'm sure there'll be a million committees and task force after this that will hope to address those gaps in our preparation. But I think the biggest takeaway for me was just that no one was running the ship.
No, absolutely, absolutely. And Travis, kind of, I have been quite aware of every single kind of public forums that you have to attend, and I know every parent has been kind of listening to what you had to say in Montgomery County, both private schools and public schools as well. Tell us a little bit more on kind of what has, you know, COVID has, and we were talking about it earlier, uncovered what is already there, kind of the problems and the lack of preparedness that is already within the system. But from kind of the social side, what are the things where, having gone through this right now, that we could prepare for to have a proper restart? And what are some of the things that you are kind of noticing within kind of the racial lines of how COVID is affecting our community?
Sure. First, thank you for the opportunity to be with you all. It's good to be here and good to be amongst friends and have a high-level conversation related to a lot of these particular issues. And as I was telling Dr. Henry before we came on, great to see you again, and kudos to the work that you're doing. I think, as Dr. Henry pointed out, is that it underscored that we do have significant issues and gaps in terms of how we respond from a national level. And the level of coordination from an emergency preparedness standpoint. But on the flip side, as you mentioned, as it relates to social determinants, it highlights that we have significant gaps in terms of the comprehensive nature of the plans and policies needed to be put into place to fully address to fully understand the impact of social determinants on health outcomes, and certainly to address them. And in this setting, in this particular setting, dealing with COVID-19, it has highlighted that when we look at disparities in outcomes, and we look at who's getting the cases and who's having worse outcomes related to it, both in terms of morbidity and mortality, we also see significant components of housing security, food security, economic and job security. Because, for example, when we say certain demographics are more likely to get it, well, that's influenced by the ability to afford housing. So when you've got you're living in an area where affordable housing is an issue, you're more likely to see multiple families living in a smaller dwelling, which enhances the potential transmission from person to person. When you have extremely issues around employment, you have a lot of folks who have to go to work. And they're frontline workers who are lower wage workers where if they are missing time from work, they don't have the ability to telework, and they don't have paid leave, and they don't have a lot of those functions. So it complicates their ability to provide economic security to their families, while also making sure they are adhering to and taking care of their bodies and adhering to public health practices. So in summary, I think it has underscored again why we need to continue to not only study and understand how social determinants impact health, we've got to actually start putting policies together that address those gaps and pull it together so that when we're talking about housing, when we're talking about job development, when we're talking about transportation access, we're thinking through how those things might impact health outcomes in the long term.
Yeah, that's absolutely spot on, and especially the way kind of you've talked about housing and any of the underlying problems that we all have is exacerbating kind of the way you deal with it, kind of the work conditions, anybody that is allowed to work remotely or not, affects that kind of significantly. You know, one of the things that, especially for the students that are kind of in this webinar right now, kind of listening in, and we have a few of them that are in the process of joining college for the first time remotely. And for a whole lot of people, the type of information that we've been getting out there, and we've tried to put it in the polls, trying to understand kind of what is the pulse of kind of the audience. How do you kind of see the way the facts as doctors and the way politics and public health has been implemented and communicated to the community, that gap, and when politics has to play a role in what you would advise to your patient, how would that kind of causing the problem, making it a lot harder? And how is it kind of, as a doctor, how do you deal with that of the messaging being hijacked away from you? And kind of both of you could take that.
I defer to Dr. Henry to start. Happy to follow up.
Okay. As a physician, you know, we don't tell other specialists what to do. And so everyone likes to stay in their lane. And so at the beginning, when our political leaders weren't, and they still aren't really listening to the recommendations from public health and medical experts about the basics, mask, social distancing, contact tracing, etc., it was very frustrating to feel that the message had kind of been, the delivery of the message had been taken away from the people who, I mean, no one's an expert on this because it was a new disease, but it just felt like this betrayal to have the words taken out of our mouths and misused, all of the miseducation that went out to people. The partisan divisions about like, why is wearing a mask like you're a Republican or Democrat? It was very interesting, like driving across the country in every state. I left Blue California and drove through the middle part of the country and came to Western Michigan. The behaviors that I saw people out in public, you know, nobody was wearing a mask after I left Colorado. It just felt like we were not being respected for our expertise, and the message was just being all kinds of misconstrued out to the public and leading to these massive numbers and deaths.
I would add to that, I think what's been interesting, if you track over time how response has gone towards public health folks. So when we were getting slammed the hardest in terms of case counts, or at least the first wave, public health folks were heroes. We were coming up with policies, you know, everyone was celebrating the public health folks and healthcare workers. But the minute that we introduced this notion of reopening, and when economics and when other policies were included, that's where the lines started to get blurred. And so now the same science that was effective at getting us to a point to reopen is now a problem because, well, we don't understand the metrics as clearly because why is this one activity not permitted in others? And unfortunately, it has been complicated not only by politics, it's been complicated by economics. And again, to the same points that you mentioned, it highlights and brings up a lot of other areas and parts of society that we've not really dealt with, and quite frankly, we don't always talk about. And it's created this tension between anytime there is a public health decision that you can cite 50 different resources, 50 different journals, and explain very clearly how you've thought through. If there is some opposition behind it, depending upon who is politically connected and who's politically savvy, you may catch repercussions from that. And I think as a resident of Montgomery County, you are aware of some of those situations. So it does make it challenging, and it's hard because I think today I'm looking at my calendar, it's like the 170th day in a row that we've worked. And it makes it tough when you have people questioning. It's one thing to question and say, I have a disagreement with a strategy that you put into place. That's fine. But when you're questioned in terms of you have been made a caricature or a monster in terms of having ulterior motives beyond trying to keep people safe. And I think that's the, you know, we all have thick skins, but that's the tough part when everybody, me, you know, Dr. Henry, others are really trying to keep people safe. That's a tough pill to swallow sometimes.
Yeah, that's got to be, I mean, I think the disrespect of the work is beyond unfortunate. It's not acceptable and it's not fair. And you're doing the best you can with the information that you have. How have you adapted to the fact that the information evolves? How do you, in you know, Dr. Gales, in your work more specifically, but also Dr. Henry in yours, how are you adapting to the fact that this is an evolutionary process?
Well, I think one of the things that we did is we recognized, to Dr. Henry's point and to your point, Meredith, is that not only information is evolving, but we don't have a grasp and handle on everything. We don't know everything. And so we actually have a panel of public health experts. I call them my advisory group, that we meet regularly, and I have a conversation, say, hey, what are your thoughts on what we're doing? What's your thought on this new issue? Can we get some feedback? Can we, we pressure test some ideas, recognizing that this is new stuff. We're taking tried and true methods from public health practice that we know have worked in other areas and applying to this situation, but it's helping us be more nimble in response. We actually have team members who their sole task is to comb through the literature every day and to find new studies and to get new reports and provide a summary. And that's usually what I read sometime late in the evening to inform the next day. And it's a challenge because I think the other component within this is a high level of humility. And being able to say, we don't have all the answers, we're learning new things every day and we're trying to synthesize it, but also being able to admit when we have to change course. And I think back to one of the probably the bigger ones is when we talk about face coverings. For the beginning of COVID, we were saying asymptomatic people don't transmit, so you don't need to wear a mask. And so everybody from the Surgeon General, us, we're like, no mask, no need, not needed. And then the studies came out that said, wait, actually, it is a benefit. And then having to say, you know what, we were doing what we were doing based upon the information. Now that we know better, we're doing better by implementing some of these other strategies.
At the Naval Medical Center, one of our issues in the endoscopy center was, as many hospitals were trying to figure out how to implement pre-testing for patients and visitor protocols. In the endoscopy center, we had to change the way we educated patients about how to prepare for their endoscopy procedures and how we manage their escorts, because after a sedation procedure, you need to have a ride home. And there was a lot of miscommunication with the changing policies about how to get pre-tested, the screening questions, whose responsibility was to call a patient who's having colonoscopy on Monday, who was going to do it over the weekend. And it really came down to, just as Dr. Gale said, just talking to people. So we had to have everyone that was on my team meet every day. We have a little team meeting, a team huddle to talk about what could come down the pipe, what we saw from the medical literature, what the Naval Medical West, our overarching regional authority, was dictating, and how we were going to change our local policies. And that required a lot of hands-on communication with every team member at every level, our techs, our nurses, our GI fellows, our providers, our front desk staff. And so it really required us to build on the interpersonal relationships that we had with all of those people to make sure everyone was on the same page and that we were educating our patients. This was only highlighted by the fact that one of our schedulers had a negative interaction with one of my managers and quit. And she was the best scheduler. And how am I going to rely on the less good scheduler to educate all the patients and tell them, okay, the rules changed this week and we're going to do this, this, and this. And so it really required all of us to use those soft skills because an institution can roll out policies, but it really is the people on the ground who are implementing them and talking to each other and patients to make sure that everyone follows the rules to stay safe. And so that was a major lesson that I learned from so far.
So I think we've talked around the edges of how COVID has really brought to realization the fact that there's a huge disparity in the way healthcare is consumed, provided, given access to Black and brown people. What are some of the things that but we haven't really dug deep into that. Let's talk about that a little bit. Let's talk about some of the things that Dr. Henry, you saw dealing with both officers and enlisted folks coming through your clinic and now as you transition. And Dr. Gales, what are you seeing as a public health officer that really highlights that in a way that maybe even is surprising to you as practitioners?
So I will say that the military is a little bit different from the civilian world in terms that we have more equal access to healthcare. I won't, disparities still exist. There are still differences in health outcomes between enlisted and officers, between dependents and service members, by region, by race, by income, by level of education. I'm not saying that the military is that TRICARE is a panacea for all of that, because those disparities still exist. However, the effect of them is blunted somewhat by an equal access or an equal insured system. And so we actually had very good access to testing in the San Diego area. We had drive-up testing that was started fairly early on. And so we didn't see some of the same disparities in the San Diego area that we're seeing with our military population that we're seeing nationwide. And I think that has a lot to do with the way that our population is insured.
Makes sense.
I think what it has, it's hard for me to articulate other than to say it just creates frustration. I think back to when I started college and, you know, was interested in health policy, and that was around the time where people started really talking about health disparities. And my first job out of college was with the Institute of Medicine, now National Academies of Medicine. And I was working nearby the group that was putting out the then groundbreaking study, Unequal Treatment, that cataloged health disparities in a way that framed the conversation. And that was in 2001. Yeah. And so you continue to, you fast forward to 2020, and we're having the same discussions about the same disparities. There's still significant disparities in infant mortality, maternal mortality, heart disease, diabetes, stroke, cancer. You name it, and they're still here. So what has, you know, we've got different names. We went from health disparities to health inequities, health equity. We've done a great job of calling it different things, but we've not done a great job of actually addressing them. And I think this gets to the earlier question of having meaningful policies that are comprehensive and thorough, that do a full examination of the real impact of social determinants of health, because then you introduce this other thing that I don't think we've really talked about, that hopefully in the current environment we are, is really talking about the impact of systemic and structural racism, as well as implicit bias on those types of social determinants. And then you can start to peel back what are the real root causes that are driving these disparities, and then hopefully come up with some policies that are addressing it. Because, you know, when I think about, when we talk about affordable housing, there are racial components to that. You know, when I think of Montgomery County, we are one of the wealthiest counties in the country. We also have significant pockets of poverty. And when we overlay COVID-19 onto that, it's not a surprise where we're seeing cases pop up. And so I think hopefully what has changed is, even though we're talking about a lot of the same disparities, is that we will have some of that really true in-depth discussion to pull apart those uncomfortable topics, to really build some policies that are going to influence things across the board to make a change.
So how do we do that? I mean, this is one of the questions that I ask every week as we look at different areas and different fields. What are the things that we can do right now, from the students that are thinking about going into medicine to the group I refer to as the old white ladies, the ladies like me, who just want to do something meaningful right now? What are some things that all of those parties can do in the face of COVID, in the face of racial inequity in healthcare, beyond? Fix it all, you two, right now.
Then that means I can retire, right? I can find a country that will accept my passport, and then I can just spend about 6 months there. Trust me, I'm looking. I'm keeping a daily tally where that can happen.
Yeah, seriously.
Well, I think part of it is asking those questions, and I think getting data, because data drives, when you have something where you can quantify the impact of some of these things to understand. And I think when I think of disparities, I think of one key example. And when we talk, what's received a lot of attention over the last year is the disparities in maternal mortality secondary to pregnancy outcomes.
Yeah.
For years, we've always written off disparities and say it's a disease of poverty, it's a disease of socioeconomic status. And maternal mortality secondary to childbirth and pregnancy, even controlling for all those things, we still see disparities. And so you can explain it through those things. And it's introduced this whole new field of epigenetics and looking at the impact of generations of exposure to trauma and racism and things like that. And so I use that as an example. When we can start quantifying what we're talking about and we take away the subjectivity of it, and we have demonstrable objective data that shows here's the impact of policy X on this outcome, that starts to change the conversation, and it puts the impetus on policymakers to have to respond, because you can see, well, here's the monetary impact, here's the life expectancy loss, here's the productivity. And I think having that quantifiable data helps drive that conversation in a way where you can start pinpointing policies that you identify that are associated with improving those outcomes.
In my work, I usually try to stay a bit apolitical because active duty service members are not supposed to express political views. But I'm free now, so I said I won't. In a perfect world, we would be able to correct the generational damages of structural racism. We would not have segregated housing. We would not have environmental pollution related to neighborhoods. Black and brown people more affected by pollutants in the groundwater. I mean, I'm back home in Michigan, and the Flint water crisis is still going on. But all of those things are so complex to fix that there's not one concrete answer to any of those questions. In healthcare, and during my when I was getting my master's in public health and during my research in healthcare disparities that affected patients with peripheral vascular disease, it was very easy to point the finger, oh, well, it's implicit bias, it's insurance, it's ethics, it's this, it's that. But no one person or organization can fix all of those things. But I think that there are some things that would make the situation a little bit better, working with what we can do now. Universal healthcare. I mean, one of the things that we've seen with COVID as people lose their jobs is the tenuous access to healthcare needed through insurance. And if insurance were no longer linked to having a job, well, it's not going to fix the problem, but it's one thing that might mediate some of the damages. Another thing would be universal pre-K and better public access to education. Another issue that's come up during the pandemic is access to childcare. I confronted that myself. I have 2 young daughters. Luckily, the daycare where they were attending in San Diego remained open for first responders, and luckily my husband was able to work from home and keep the girls home, but not everybody has that luxury. Right. And once we moved past COVID, the access to daycare, access to early childhood education, high quality childhood education has been shown to impact long-term health outcomes in our communities. And I think that those are things that we can fix right now.
Yeah. What about access to food? Because I think access to nutritional food, because I think one of the things that we've seen repeatedly in our area is so many kids, when school closed, lost their access to a healthy meal a day. And how do we, I know that this isn't a medicine problem necessarily, but what are some of the things that we can think about around childhood nutrition and access to healthy food?
Well, I think it is a medical problem because it's a problem in terms of how we practice medicine and needing to change how we only look at biomedical solutions to issues. And I think growing the practice of medicine to be more inclusive of recognition of those social determinants, so food security, as well as, you know, access to those other social services, I think is a core important criteria in terms of the practice of medicine. And I think that it gets to, for example, I can think, you know, when we look at type 2 diabetes. So before COVID hit us, that was one of the areas that the state of Maryland had prioritized from the State Department of Health. And we were tasked with local jurisdictions to coming up with strategies to combat that. And so one of the ways that we looked at it is, you know, given my background in HIV medicine, it was kind of like, you know, the Ryan White Care program, which basically is all about social support and linkage to social determinants of health so that people living with HIV would have better outcomes. But like, why don't we apply that model to type 2 diabetes? So if you're coming into my clinic or you're coming into my emergency room and I see you have an elevated A1C, so we'll fix that. You know, we can address that from medicine, but, you know, what's driving that? Do you have access to food security? So whether you're a child or an adult, what does that look like? Can we get you connected to those services? You know, because we know that if you're eating healthier, it's going to improve your health. But then also it takes one less thing off your plate that is keeping you from being able to focus on taking care of your health. And so I think that's a long-winded way to say that I think if we redo how we look at the medical practice to be more inclusive of those strategies, I think we can help from the medical management standpoint.
Makes sense.
I mean, food deserts are something that affects nutrition, obesity, and has downstream effects on so many different diseases. And addressing that with cities maybe changing their zoning laws or encouraging development of and placement of actual grocery stores instead of bodegas or fast food restaurants in underserved communities would at least make food more healthier food more available.
Mm-hmm.
For a lot of people, when they see that the problems are like really multifaceted, it includes access to food, access to education, access to healthcare, access to like all kind of different stuff. There's this sense of, oh, see, we can't do anything about it. It's so pervasive. It's everywhere. Like there's no solution really. Like you can't really do anything about it. And COVID is, I think we're not going to get any opportunity down the line as big and as critical as an excuse for politicians to be held accountable, for policymakers and everybody, as you mentioned, Dr. Gales. And I think, Dr. Henry, you've said it beautifully, and I want to kind of get your answers for both of you on there, where when you talked about just safety net, the basic safety nets of making sure that there's basic universal health care, universal education, universal things that provide kind of basic resiliency to the countries that have that perform a lot better. And what are some of the policies so that the answer is not, hey, it's so pervasive, it covers so many things, it can't really be solved right now, it's a generational thing. What are some of the things that you see and you think are the answers that all of us that are here could push for in our own little worlds to advance in bringing about change? Because at the end of the day, the one thing I heard from you, Dr. Henry, is that kind of this universality of a solution will bring about making sure that we're all able to really survive tough things and tough situations as a country uniformly.
Well, there's an election coming up, and go vote, register to vote.
Right.
Pay attention to your local offices. I mean, everything isn't just about who's going to be president. I mean, that's like the most celebrity, but you know, we had a Black president and life didn't like turn around 100% for all of us. I think Obama's great. However, you know, run for office, get involved in your local politics, give to an organization that's lobbying for things that you believe in. I actually served as a page in the House of Representatives when I was in high school and had very early exposure to the impact of lobbyists on our national agenda. And so we need to combat that. But the only way we're going to do it is by having people in office who believe in supporting communities who believe in having sensible solutions, but they need to be in office. But you can't just have a one-term person in the House of Representatives. They have no power. They're not on any committees. And I think that we need to focus on our own communities, on who we're electing to local boards, because those are springboards to who gets elected to Congress, and support people who have who share that perspective.
I would say there are two things I would add. I think one is one of the approaches that we took, again, pre-COVID, to get all of our elected officials and different department agency heads engaged in public health is we adopted what's called a health in all policies model, where we brought all of the department heads across county government and some of the elected officials as well to teach them about how health is impacted by their different agencies and the decisions that they do. And so we ask them, as part of that process, is when they make decisions as part of their master plans and those kind of things, that they think through what would the impact be on public health outcomes related to those different things. And we've worked with them to see, for example, I think of the Department of Transportation, from pedestrian safety. We have had a lot of pedestrian related fatalities. And so we were able to sit down and come up with a plan that looked at, well, it's not just a question of where people are walking, it's what types of neighborhoods have speed bumps and sidewalks, which types of neighborhoods are disproportionately reliant on public transit, and where are the bus stops, they before the intersection, after intersection, to be able to think through, again, when you're thinking just roads, you're thinking, here's where I'm putting things, but think about how that impacts the outcomes. The second component, which I'm most excited about, and there's a lot of folks on the call, is the younger generation, in terms of their willingness to be active, to ask those tough questions, to not only ask those tough questions, but actually demand answers in that space. And what's been interesting over the last 6 months is that has been helpful, I think, to push the conversation where we are having those, or at least we're forced to have those more meaningful conversations about what is diversity and inclusion, what is, what's implicit bias, what is structural racism, and how do those things actually impact not only just health outcomes, but outcomes across the board. So to the younger generation on the call, keep up the good work, keep pushing us to keep moving things ahead. And so we can create space for you to come in and execute those particular agendas and guidelines.
And to that point and to that population, because they do make up a really important part of this seminar series, you both came up through medical education in America in the last 20-ish years. It's, I hope, getting better, but it's still it's a tough route. Any advice or suggestions to folks that are thinking about medicine as they get through their undergrad years, and what you'd tell them to think about and not think about?
I would say it is a long, hard road, but I think one of the most important things, and this ties, I think, into the impact of the Ron Brown Scholars Program, one of the things that I've always talked about and have been grateful for, among many things, is the value of mentorship. And it's important to find people who have charted out a path that may look like what you want to do, and even if it's not, they can help you identify the landmines and move around the landmines to be able to deal with stuff, because you're going to encounter obstacles. That's just a given. And it's important to be able to have your core group of people who can give you that advice and say, I think this is you maybe want to rethink about this class, or maybe rethink about how you're doing this, or supporting you and say, I think that's a great idea, particularly if you're charting out a path where there's no set way of here's how you do it. And that power of mentorship has been great. I still have, as I mentioned, we have our advisory group in a professional sense. I call them my informal gang of 5 that I call with, questions. For example, one of my longstanding mentors I got from or met with the Ron Brown Scholar Program, Dr. Vivian Penn. Now, Dr. Vivian, I get on her because she's on email way too late in the night, but I'll send her an email and we'll be talking, and I'll say, can I curbside you, get some advice on this? And she doesn't hesitate to say, well, think of it from this perspective. This is the long game. Here's the short game. Here's what you need to think about. And so I would say find mentors and find people, and mentors come in different sizes, ages, genders, races, backgrounds. And so find people who are committed to supporting you and who are willing to be able to provide you that advice and guidance to kind of, skip over those hurdles, push past those obstacles to get to where you want to be.
Dr. Hen?
That is excellent advice. Having mentors is so key because there are so many road bumps, as Dr. Gale said, on the way to finishing residency and becoming a practicing physician. And I think that if you don't seek out and heed the advice, or at least, think about it carefully that you're given, you could find yourself in the wrong specialty, in the wrong field, missing opportunities. So not just to have those mentors, but to really listen to what they have to say. You don't have to do exactly what they did because everyone is on a different path, but listen to them. Yeah. The other thing I would say is just have faith in yourself. It's a long road, and a lot of it is done by yourself, up late studying for an exam, at night on call by yourself, with a sick patient. And it's that faith in yourself and in God that's going to get you through it. So just have faith in yourself.
Yeah. So we're gonna start digging into some of the questions that come out of the Q&A and the chat. And sometimes I lack the context on these because I'm simply reading them. So we'll start with a question about, I'm going to paraphrase this one. A lot of African countries are doing pretty well with COVID. And here in the US, we aren't doing as well at all, even close. Any thoughts on, not just, I don't think we have to limit it to countries in Africa, but what we're missing that seems to be being managed better in other countries, even in countries where there are more people living closer together and more poverty, so forth? I know that's a big question.
I think the first component is there's no national strategy. There's 50 different states, different municipalities doing different things. And it creates tension and turmoil because we don't know what standards to apply. So whether we're talking about, face coverings, we know that it's safe, we know that it works, but there's no national strategy around that. When we talk about increasing access to testing, we know that testing, meaningful testing and getting access to rapid testing or quicker results allows for more effective contact tracing. There's no national strategy for that. When we talk about distribution of personal protective equipment, and we're already talking about strategies for flu vaccination this year, as well as dissemination of a vaccine if and when we get it. There's no national strategy for any of that. And it complicates things because it then sets up situations where we did have a wave of states who did move well. Illinois, New York, California in the beginning to some degree, Maryland, Virginia, we had states who had seen significant improvement, but at the same time, we were hit with 40 other states who saw upticks in cases that have now driven up cases in those places that did well. And so I think not having a national strategy to address a lot of these different issues, to create a uniform, standardized approach has complicated our ability to move forward, more so than some of these other countries where there has been more cohesion from top down that has allowed for the response to move forward without as much injection of politics and economics and other factors in there that have complicated the argument.
Mm-hmm.
I don't have much to add. I hope every day that I turn on the news that the story has changed and that we start following the guidelines. I still have hope.
I'll take that hope. So another question that's coming out of the Q&A and chat is, and we talked a little bit about this before, and it also has to do a little bit about, it has to do with this question, but there are certainly populations that are less trusting of the medical community for many good reasons. How do we re-engage Black and brown people to trust in this time when they feel like they're really not getting good answers? what are some of the things that can be done to re-engage them so that they feel more comfortable trusting research and recommendations and getting engaged in healthcare? I think that's marginalized communities in general.
Well, I mean, the same thing that we've done for years, trying to get African American communities engaged in medical research, and given the history of the Tuskegee experiments, is just direct outreach, meeting people where they are in their communities, like houses of worship, the barber shop, the beauty salon, and having people who look like them conveying the importance of attacking this so that we can all move forward.
Mm-hmm.
And I would add, I think research is always tricky because part of the challenge is we know that we need more diversity in research studies so that we have a better understanding to be able to trust the medications and the practices and policies, because we know we've actually been a part of that conversation. But I think one of the things that we have to take a step back, and this is just my personal opinion, in terms of how we deliver medical care and public health services, is we can't always lead with a disease or an adverse outcome as our method of engaging or the reason we engage communities. And I think if we start engaging communities around this notion of whole person health and wellness, where we're talking about how social determinants impact health, and we can have conversations about racism and bias and how that impacts health, as opposed to just leading with, you have a worse death rate or you have a worse outcome, right, and it's because you're not taking care of yourself. I think that opens up opportunities to create conversations that will build that social capital and that rapport and that sense of respect and trust in the system, because I feel like you care about me as a person as opposed to seeing me as a research subject. And then I think that gets to, and it's a shame that we're in 2020 and we still have to talk about needing to do that kind of stuff, and it's frustrating. But I think that opens up the door to be able to then, have some of those conversations to dispel a lot of those myths that people may have in the system, and to talk through what it means to be in a research trial, or talk through, the ramifications of different policies. And so I'm hopeful. I group that in that other conversation about how we can kind of redirect how we practice medicine. I would group that into that same toolbox, and hopefully would lead for better engagement.
Just dovetailing on that, I mean, that brings up community-based participatory research, where it's research with, not research on, and engaging the community to find out what are your health priorities and how can we use our resources and leverage that to help the community meet its own goals.
Yeah, definitely.
And what is your advice on reopening in general? Especially for kind of students that are making a decision, should I go back to class? I just did a survey. A whole lot of them really don't want to go back to class in the fall. What are the criteria where you make that judgment?
Well, you make it based upon science and data. Science and data. I think, the factors that we're looking at, we continue to look at and preach, whether, again, we're talking about schools, businesses, personal services, entertainment, all those kind of things, is really driven by seeing lower rates of community transmission, lower community viral load, lower daily caseloads, lower utilization of healthcare facilities related to COVID-related care. These are all, and there's test positivity. There's a whole host of measures that I think folks can use. And it's just important to remember the context, because people will follow a number. For example, everyone right now is following test positivity. Test positivity is a great measure, and test positivity is measuring the number of people who test positive divided by the number of people you're testing. And so now everyone's like, oh, wow, our test positivity numbers are so low. And we were at, I think in Montgomery County, we were at 40% at our highest. The context is, yes, we have made improvements where we are seeing lower cases and we're testing more people, but we also have to remember when we compare to that 40% in May and June, we were only testing people who were symptomatic. We weren't testing everybody. And so I think it's important that when we look across that dashboard of data points, we remember the context within which those numbers exist. But I think the core principle is low community transmission, because the key is if we can drive down as much of the virus we can in the community, we can feel more confident when we open up stuff and increase capacity and increase that there's going to be less virus being introduced into those settings that would ultimately cause transmission.
I mean, it's tricky. A lot of people are concerned about schools, and as a parent, I mean, I see my 4-year-old is, you know, not remembering things that she learned in preschool, like back in March, and I'm not a preschool teacher. I think she should go back to school. I hope that we're not in the same place where we were in March. I've carefully read through the policies and practices of the school that she would be attending now that we've moved, visited, and I've seen, you know, that they're following them. And so I'm balancing sending them back to school with their need for ongoing education and missing out because she needs to be ready for kindergarten, and hoping that what I saw on the tour is, you know, what's actually happening on a day-to-day basis. But if I have a very low threshold for if there's an outbreak, people are getting sick, okay, well, everyone's pulling back and everyone's going back, staying at home.
So it's probably a little late and it's unfair to ask this question, but, you know, just for fun. We all have run into those folks who say, it's not that bad. This is all fake news. I could go on with all of the rhetoric. Give us 3 useful things to say to people like that to help explain and help them understand why this is real and it is a big deal. It could be 2 things or 1 thing as well.
Well, part of the challenge is that you would hope simply by showing the numbers that 165,000 folks have died and over 5 million people have contacted COVID-19, you would hope that that would resonate with folks. And I'll be candid, I don't know if I have the skill set to be able to penetrate and convince people who aren't moved by those numbers in itself. I think the challenge is that unfortunately, it typically takes someone having COVID get into their network, and for folks to really, it becomes personal for them. You know, I think, and this isn't even an extreme example, I think to my, you know, about my parents. They live in Southern Virginia, and I call them daily because they're in a high-risk age group, and I'm like, what did you do today? Who did you see? Where did you go? Anything high risk? And for a while, it did, you know, it didn't really resonate. They're like, well, you know, we're in the country, no one's really here, but the cases have increased. And now they actually have friends who've had it. And my father's best friend, fortunately, everybody's fine. My father's best friend's son and his wife had it. And they're okay, but it was like, oh, wow, this exists. And we recognize now when you're telling us to go to the grocery store at certain times and to limit, you know, who we're interacting with. And so I think in the absence of just the real sense, I think, you know, making it more personal and showing people here's how this could impact your life and impact your network.
Yeah, I mean, we always assume that if you know better, you'll do better. But there's this kind of like lack of logic and the rationality that has been pervasive, you know, since this all came out. When I have family members who are not following the guidelines, I just have to stop and say, okay, what about this don't you understand? Because if someone's going to get it, it's going to be you, because you're Black, you have diabetes, you have hypertension, and it's not going to end well. And I just try to engage them in conversation to find out, like, what are your hangups? Like, why don't you think that this is a real thing? And eventually, you know, they kind of run out of reasons to rationalize their behavior, and they come around and say, okay, I guess you're right. Mm-hmm. A lot of handling.
Yeah. Any suggestions on how to make people wear masks? That's a question out of the chat. How to police it? How to enforce it? And what masks should they wear?
Well, there was a research study that came out from the nation's finest institution this week that talked about the differences in masks in terms of which ones are safer to use. And so it did reference to say that there is some variability in terms of the level of protection dependent upon the mask. So I would encourage folks to follow up on that study. I think because the reality is, unfortunately, it's not always safe now, as we've seen in terms of interactions where if you go to someone and say, could you please put on your mask? I would recommend, particularly if you're in a business setting, is letting the owners or managers of the place know your concerns and have them do it. From a safety standpoint, I think unfortunately there was an example of an amusement park, a young person who was working and asked a couple to wear a mask, and they assaulted him, and he ended up with a broken jaw. And so I think from a safety perspective, consider using some of those strategies to be able to address. Because the other thing that's important is not only are individuals held accountable for wearing face coverings and adhering to the guidelines, businesses are required to have their customers wear them. So businesses have a pressure because if there are complaints filed against the business, they face the reality they may have to pay a fine or be cited or be shut down, and none of them want to do that either. So I would encourage in those settings, if that's possible, to use that mechanism.
I mean, 95% of people, if they're not wearing a mask, if you hand them a box, like, okay, please put this on, they're not going to argue with you. It's just that 5% that are, going to get into altercation. And for them, there's no good answer. I mean, you're putting the salesperson, the security guard, et cetera, at risk. But it does need to be reinforced. And I don't think we've come up with an acceptable way of doing that.
Well, at least we've been able to see a whole lot of memes and and viral videos of creative posts by shop owners. But no, absolutely. It's sad that a very small percentage makes it quite hard for the majority.
Mm-hmm. Yep. Sam, you got anything else?
No, just the final question that I have is around kind of contact tracing and some of the different stuff that have been suggested. And what could go wrong specifically for those, and how it could end up creating kind of geofencing of based on racial, socioeconomical communities and not just even talking about the privacies, but there's also significant benefits of contact tracing, freeing us to open up a lot more. So what is kind of your view around contact tracing and some of the things that we need to be careful about as we're all kind of engaging with them?
Well, contact tracing is an important public health tool to be able to do, from a disease control perspective, and working to identify cases as quickly as we can to get them tested. Now that we can test, we have broader testing and isolated to prevent further potential transmission. One of the things that we didn't think about necessarily when we rolled out contact tracing in the early stages of COVID-19 was the fact that, because from public health, we're like, if we call you, we need you to answer your phone. But the reality is we're in a special time right now where there are lots of communities that are not trusting of the government. When they see a phone number they don't recognize, or they receive a letter, they don't trust who and why are you calling me asking these questions. And so what the state did actually, and we've done some on the local level, is to provide that education to say, if you get a call from this number or this person, here's why we're asking you these questions. Here's why it's important for you to answer those questions, and reminding folks and hopefully getting them to trust. And this gets to your earlier question about this mistrust in the system, unfortunately. It complicates this, and getting folks to understand we're using this information not to keep it or sell it to the federal government, but to help keep you and your family safe. And so part of that is also recognizing that we don't always have the answers. We had a meeting today to talk about how we can engage young people, because we're seeing a higher percentage of cases pop up in younger ages. And I don't speak 18 to 19-year-old. I don't even speak 20 to 30 anymore, unfortunately. I'm gonna stop right there. I'm not gonna go any higher. But with that said, utilizing some of those groups to do some key messaging so it resonates with people, so they understand the value, the purpose, and why they're getting that call.
And I think it's also important that we talk about the resources being devoted to contact tracing, because it's clearly insufficient.
No, that's a very important point. So with contact tracing, just kind of really just one part on this, and we're over the time right now. What about the automated solutions that Google and Apple have been kind of suggesting of kind of Bluetooth methods where it is away from the way traditional contact tracing has been done through public health, but more of kind of a more invasive way and having that information and how that could that kind of data could be dangerous. But I guess kind of the key point that you've raised, which is important, is around the education part.
Yeah, I mean, I think that people need to kind of release the facade that they have any privacy, because all the apps on your phone are tracking where you are, your contacts, you're pinging Facebook, oh, I checked in here, I checked in there. You have no privacy if you have all those apps running with your location. So why are you upset that something's trying to help you?
Yeah.
I mean, I understand the trust in the government. However, if you trust random apps that you're downloading in your phone and you have no idea what they're doing with their personal information, why can't you trust public health?
Yeah.
That part of this distrust is a lot because our national leadership is creating the term fake news. And so it's not helpful.
Yeah.
And I would just add one thing to that, because I can't be quoted saying that, but what she said is it speaks to the need to innovate and modernize our approach. And so, you know, we in public health, we have been screaming, wanting, you know, additional funding to do that. For example, when Dr. Henry mentioned contact tracing, budgets, so typically contact tracers have been a part of our disease intervention specialists who do outbreak investigations for mainly sexually transmitted infections and tuberculosis. Those budgets have been cut significantly in the last 5 to 6 years, and we've lost half of that workforce. And so you can imagine you throw in a pandemic, and now we've got to use, you know, a strapped set of resources already to be able to go after it, and using some of the more less technologically savvy tools, such as all the things that you mentioned. I don't even begin to know all the technology that you mentioned, Sam, but what you said is it's an opportunity now to think through when we can, as we continue to work through COVID-19 and as we rebuild for post-COVID-19, I'm confident we are going to have a post-COVID-19 world, is supporting innovative strategies to rebuild public health. In terms of how we respond, in terms of how we do things. And to Dr. Henry's point, yes, that information is being tracked already. We actually get a monthly report that looks at I think it's called the proximity measure, that looks at how far residents have gone from their home to other places. And, you know, the jurisdictions are looked upon that. And we've scored fairly well here in Montgomery County. But yeah, you know, a lot of information is tracked already and collected, whether we know it or not. And it creates the opportunity to talk about how we leverage those things in a meaningful way to sustain this response, but to also improve service delivery in the future.
Yeah, good points. You guys, thank you so much. Sam, go ahead. Sorry.
No, please, Meredith, go ahead.
Just thank you. Thanks for being candid and coming to talk about something that we're all learning about as we go. And thank you for spending the time with us today. Sam, I'll throw it to you.
Dr. Gales, Dr. Henry, really, really appreciated. I've learned quite a lot, so thank you so much for your time. And everybody, we might have to changes for next week, but we will send an email out.
Yes, awesome. Thanks everybody. See you next week. Thank you. Bye, you guys. Thanks a lot.